determining when and for how long to discontinue a wound vac therapy in a patient within a Parkinson's disease PD and diabetic neuropathy depends on when progression, underlying complications, and response to treatment. Here's a structured approach to evaluating effectiveness and making decisions. Hashtag and when to consider stopping a wound vac diet. Hashtag Proctor 1. No improvement after 4 to 6 weeks. Expected progress. A properly managed wound should show increased or reduced size, granulation tissue, pink-red healing tissue, and decreased drainage within 2 to 4 weeks. Failure signs and no reduction in wound size after for 4 weeks, increasing necrosis, dead tissue, or infection, pus, foul odor, worsening redness. Persistent or worsening pain may indicate ischemia or infection. Hashtag 2. Wound deterioration despite vaccine if the wound expands, dens, deepens, or develops new tunneling sinus tracts. The vac may not be addressing the root cause, e.g. pressure, poor circulation. Hashtag complications from vac therapy. For skin irritation, breakdown from adhesive dressings, bleeding or excessive pain, rare but possible with fragile tissue, recurrent infections. If biofilm or osteomyelitis is present. Hashtag Control 4. Underlying issues not addressed. Uncontrolled diabetes, HbA1c greater than 8%, impairs healing. Severe neuropathy. Ongoing trauma from unnoticed pressure. Poor circulation. PAD, arterial insufficiency. Requires revascularization first. PD-related gait problems. Continuous pressure friction on the wound. Hashtag on how long to trial a wound vac before deciding. Or test scenario trial period or act steps if no progress. Or next if or in chat or clean non-infected wound or 4 weeks or reassess offloading infection vascular status or infected wound on antibiotics or per 2 to 3 weeks, or if no improvement, switch to antimicrobial dressings plus culture-guided IV antibiotics, or ischemic wound, low blood flow, or discontinue early PONUS, or vascular surgery consult before continuing VAC, or on the wound with exposed bone tendon, or 4 to 6 weeks, or if no granulation, consider surgical debridement, flap closure. Hashtag key factors in PD plus diabetic neuropathy patients. One, if the patient offloading is crucial. If the patient keeps walking on the wound, even a VAC will fail. Solutions. Total contact cast TCC, gold standard for diabetic ulcers. Walker wheelchair use prior to eliminate pressure. 2. Neuropathy and PD gait issues. Even small amounts of friction can sabotage healing. Custom shoes plus pressure-relieving insoles are a must. 3. Medication adjustments. Some PD meds, e.g. dopamine agonists, worsen edema. Hashtag for what to try if the wound vac fails. 1. Upon advanced dressings, brown hydrogels, collagen, silver dressings. 2. Hyperbaric oxygen therapy, HBOT, if hypoxia is suspected. 3. Growth factor therapy, e.g. bicaplermin gel. 4. Surgical options, debridement, skin grafts, flap reconstruction. Hashtag Hinser and final recommendation to re-evaluate at 4 weeks if no progress. Stop VAC if no improvement after 6 weeks with optimal offloading, wound worsens or complications arise. And multidisciplinary care, podiatry, neurology, endocrinology, wound care is essential. Would you like guidance on alternative offloading methods or how to optimize PD management for wound healing?